Okay. We now come to the fourth session on Trisomy 21, the early intervention program. And then we talk in general about the general management. In the earlier sessions, we talked about the various systems that were involved and how you were to manage them, their follow-up and the recommendations. Now, counseling is the most important part of it. The question is, how do you counsel? Whenever you want to counsel, you got to see that you have ample time to spare for the parents, both the parents, the father and the mother, and preferably somebody whom they have confidence in. Basically, you can get the mother's parents to be with you for the counseling session. They should be totally relaxed, seated, and you should be patient enough to talk with them, taking without any interruption. When do you counsel? You counsel immediately as soon as the diagnosis is made or clinical diagnosis is made. You tell them that you are suspecting it's a case of Down syndrome, and then you've got to follow up and work it up. The reason why you should tell then is, if you don't tell it then, there are many patients who don't come for a proper follow-up, and they lose a proper counseling, and the diagnosis of Down syndrome is conveyed to them only at about 1 year of age, when the child refuses, the child does not start walking. And by the time the early intervention part is totally over. So this is very important. As soon as you suspect a clinical diagnosis of Down syndrome, you got to counsel them. And after all the workup has been done, both the karyotype and the various system, so that you know what exactly the child's problem is, you can answer the questions in a better way. By whom? A pediatrician or somebody with whom maybe the gynecologist at times can be there, but preferably it's a pediatrician, because the pediatrician is the one who is going to follow up the child. And to whom, as I mentioned earlier, both the parents should preferably be there when you are counseling them, because whatever question both have to ask should be cleared then and there. Because if it's only to one of the parent, then the other parent may have a lot of doubts, which again will lead on to a lot of misunderstanding. So the counseling and the management should be a combined approach. You should have the pediatrician or the physician if an older child is being seen and young adult is being seen for the first time, an ENT surgeon, an ophthalmologist, cardiologist, orthopedician, a dental surgeon, a geneticist, and a genetic counselor, along with a developmental therapist, a physical therapist, occupational therapist, speech therapist, a behavior therapist, a clinical psychologist, a social worker, and of course, support group. I'll be talking about it later. So this is a combined approach, basically, with all the systems, because all the systems can be affected. And then the therapy is involving all these areas, and all these experts should be there in the management of a child with Down syndrome. So when do we begin? Many people say you can start it by 3 months, but I would say on day 1 or on first contact. The moment the diagnosis is made, or as soon as the child is born, and if you have made a diagnosis, we should start early intervention program. But it should not be delayed beyond 3 months. You got to assess the child, and sensory integration program has to be brought in, and we got to be with the parents. The children should be with the parents, and integration program should be started immediately. The mother should act as the first therapist, and it should be play-based, because a therapist per se may not be able to do anything in a child of that age, though a therapist can assess and recommend what is to be done to the mother. A physical therapy is basically joint movement. See that all the movements of all the joints are being moved at least once a day, or maybe even more, especially during giving a bath. An occupational therapy, what you do is a tactile, the sensation of touch. You can start with that. They can have a feeling of the different textures, like a rough cloth of a Turkish towel, or a fine texture of a silk, so that they are getting used to the various tactiles and various things as part of the occupational therapy. Speech therapy, again by mother initially, somebody has to keep talking on to the child. The mother is the best person to keep talking to the child. Speech stimulation is what it is there. And keep on talking to them so that they are stimulated to speak and the clarity of the words get into their mind. Psychological support to parents and other children. Now, this is something very important and very often missed because the parents do need a lot of psychological support. After 9 months and expecting a normal child, and then you are suddenly going to tell them, well, this child has some problems. It's a great psychological blow to many of the parents. So you need psychological support to tell them, no, you can manage it. It's slightly different from the other children, but then you got to handle it. And also the other children, the siblings. I know of cases where the elder sibling does not want to tell her classmates that she has got a sister with Down syndrome. So how do you handle that? So psychological support to parents and other children are very important for the development of the child also. Speech and language, as I mentioned, speak to the child. You can read to the child, an older child, sing to the child, and then improve the communication skills. What is told is that singing gets into your head faster than all the other methodologies. That is why probably in our younger days, we were given nursery rhymes, which many of us still remember, even though we have forgotten a lot of things. So the area in the brain concerned with singing, that retains a lot more than the other areas. Orofacial exercises are very important because, as you mentioned, there's a mid-maxillary hypoplasia and a slightly larger tongue with a thick tongue, which is maybe difficult in having a proper speech. So the tongue and mouth and swallowing and speech, they should be exercises so that they can use their tongue and mouth in a better way. So there is clarity of speech. So that is very important. And the exercises should be started at the earliest. Self-care skills, activities of daily living, dependence. Initially it is that, and then it is assisted. And finally, the child should be able to have an independent living. Grooming, dressing, toileting, mobility, all those should be gradually brought into the child. As any other child, they take their time, but these children take a longer time because of various reasons. So that is very important to see that these aspects are basically looked into, taught, and trained. Schooling by 3 to 5 years of age, what is the normal thing? You can either send them to a play school or an Anganwadi, so because they have interaction with the other children and they start picking up what is being taught to normal children. But going to a normal school, what is recommended is only about after 8 years, because if you send the child to a normal school by 5 or 6 years, the child will not or may not be able to handle or grasp what is taught in the class. So that leads on to indifference and lack of interest in studies. Whereas if the child is, say, 8 or 9 years old at the time, after doing an IQ test, you can send the child to a first standard. The child is able to follow what the teacher says, and the interest to study may also be kindled. The child should not be sent to any special school because these children are mild to moderate intellectual disability only, so they can be trained, so they should be given the maximum benefit of a normal education. There's a vocational training and support by 15 to 70 years. As I mentioned, they are highly trainable, and then after 20 years, they should be able to live on their own with a proper vocation if they are properly trained. Now, these are some examples of the therapy rooms from one of the institutions where you can see that the various things. So they're all stimulation, help to stimulation. We have various institutions all over our country and especially our state where you have all these facilities. The school-based therapy is the music therapy, as I mentioned earlier. Music has got a wonderful way of getting into your head and staying there. Play therapy, dance therapy, and yoga, they can all do wonders, and they should be initiated at the earliest. Now, this is a session of a play therapy where their brain is stimulated as to what is to be done and how is to be done, make them think about the various aspects. And this is again another form of play therapy where they are given the liberty to do what they want. The brain is to be stimulated. The creativity is being brought out. Now coming to the follow-up after these, as I mentioned, you've got to go in for all the therapies at the appropriate time. I'm not going into details of all those things. I've told you how to start the therapies by the mother, and later on, as the child becomes older and older, you go in for a definite therapy sessions with the concerned developmental therapies. You have the physical therapists, you have the occupational therapists, the speech therapist, the behavior therapist, so that as the child grows up at that typical age, you go to start on all the therapies. So what do you do for the following up the child? At birth, karyotyping is essential, as I mentioned, to confirm the diagnosis and to find out what sort of a Down syndrome it is, and for counseling the child, either the initial counseling and later on when the diagnosis is made. Complete blood count is required to find out if there is any case of anemia, leukemia, or any of those things. A full thyroid function test, a cardiac evaluation, definitely at birth, and it has to be confirmed by about 6 weeks of age. A hearing evaluation, OAE, at birth, the other tests at a later stage. Ophthalmic evaluation by 4 to 6 weeks. The pediatrician should check for the eye movements, and by 4 to 6 weeks, the ophthalmologist will just screen through any major problems. Record the head circumference, height, and weight, and plot it in a Down syndrome specific chart if possible. Proper general and systemic examination. We are going to the systemic problems. A PACA general examination, the systemic examination, should be done at birth to rule out any other problem as with any other child. And counsel on the occupational therapy, physical therapy, speech stimulation programs, as mentioned earlier. By 6 months of age, the thyroid function should be repeated. A full audiological review should be done. The brainstem evoked potential should be done, even though if your OA is or was normal at birth. An ophthalmologic checkup, record the head circumference, weight, and height, should be plotted at each visit on a growth charts that have been adjusted for children with Down syndrome, but preferably in a Down syndrome specific growth chart. If that is not available, a normal chart which is adjusted for children with Down syndrome. And the therapies, as mentioned earlier. 1 year, again, is CBC, thyroid function. The free T4 is preferred, TSH once in 3 months if hypothyroid. Monitor growth and development, a dental opinion, hip and foot evaluation the first year of life. 1 to 5 years, the height and weight should be plotted on growth charts. Hearing evaluation at 18 months, thereafter yearly till 5 years. Ophthalmic evaluation also at 18 months, and thereafter once in 2 years, that's the 2 years and 4 years, and later on 2 yearly. Dental checkup should be yearly till 5 years. Orthopedic checkup for the hip, foot, and spine, and also the atlantoaxial instability checkup for any symptoms and signs related to that. Thyroid function and CBC once a year. 5 to 13 years, height and weight should be plotted as before. Hearing and ophthalmology evaluation every 2 years. Dental checkup annually. Thyroid function yearly. Dermatological problems, they start coming by this time. They normally have a dry skin, but then during puberty, it can be extreme dryness, acne, and other problems. Sleep apnea is not uncommon. Many of them have a problem, obstructive sleep apnea, especially once the child starts putting on weight. So that should be looked into. Ideally, all children should be tested for that. A sleep study should be done, but it may not be practical in all children. And a celiac disease, depending on whether there are any symptoms. The teens and young adults, a dental checkup yearly, hearing and ophthalmic evaluation 2 yearly, dermatological problems, especially during puberty, as mentioned earlier, a thyroid function early. In puberty, discuss physical and psychological changes and the need for gynecologic care in subset females. Sleep apnea, again, that's the matter of concern. Adult care, it's not enough that we take care of the the earlier stages, the teenage stages, and then leave it to the adult physician, because they may be also at a loss as to what is to be done. So adult care should be handed over to an adult physician, but then these things should be highlighted. There can be behavior changes. The signs of mental health problems and dementia. Dementia is quite common. There is lack of brain maturity, but even though it is there, later on they start having problems associated with dementia. So that has to be looked into. They have to be stimulated to keep their brain working. Weight gain and signs of obesity. Many of the children do have signs of obesity because they don't have any physical movement is less, and they eat a lot. There's no control in the eating, and because of those things have to be carefully looked into. Cardiac problems, even though there were no cardiac problems initially, congenital cardiac problems were not there. You can later on have mitral valve collapse and aortic regurgitation. Hearing and ophthalmic checkup every 2 years, annual dental checkup, look for sleep apnea, and thyroid evaluation as needed. If you're suspecting it, you don't have to do it yearly in dental care. Now, this is just a chart on what ought to be done at different ages. The karyotyping at birth, usual preventive care all throughout, audiological evaluation, OAE at birth, and the ABER later on. Ophthalmology, how frequently you should do it, thyroid, dental, perinatal support, and developmental education services. Now, it is always better to have this chart or a similar chart and hand it over to the parents at the time of the first contact. So they know when to come and what is to be done. So even if they go to somebody who's not fully aware of it, they can show this chart and say, look here, my child is 5 years old, and see, these are things that have to be done. And so it is not missed. A proper workup is, a proper follow-up is properly done. Now, the future of therapy, what can be done to children with Down syndrome? You have the gene therapy. We all know it's basically a genetic problem. And then in what way can you handle it? Drugs have been tried to suppress the expression of the extra chromosome. As mentioned earlier, chromosome 21 has about 350 to 400 genes. And what is told is that about 130 to 300 extra genes are there, normal extra genes, and they produce all these problems. So that is the reason why you have all these manifestations. So the therapy to suppress those extra genes so that the child will have a normal upbringing. And drugs to improve the cognition that are also being tried, basically because they are mild to moderate intellectual disability, how to improve on these cognitions. So these are all what we have for future therapy of how it can be done, how we can manage the future. Okay. Okay. Now this is all the photos that I have shown are of children and adults with Down syndrome who are excelling in their field and who are doing working. He's running a hotel, and what people say is they come to him because of the smile, the bewitching smile, more than the taste of the Soleimani that he provides. So what is our role as doctors or others who are involved with the management of children with Down syndrome? Basic thing what we should not forget is detect early. Antenatal, I've not gotten the antenatal checkups and antenatal detections because of paucity of time, but antenatal and postnatal, you want to catch them at the earliest so that you can start early intervention programs. They should be started as early as possible. Very often they are missed because the diagnosis is made late, or the diagnosis has been made at birth, but it's not been properly communicated, or the seriousness of having a regular interventional program has not been understood by the parents. So that is why I said, as soon as you make a diagnosis, you make a counseling, and then repeat it so that they know that what has to be done at each developmental years of time. Counseling and support to the parents, very important to the parents also, not merely telling of the child, because it's a tough job for many of the parents. There's an extra work they have to do to bring up the child, and then that needs a lot of counseling and support. Have a regular meeting, maybe once a month or once in 2 to 3 months, of a support group. And what is our role? So what is our role in the management of these children with Down syndrome? Early detection is very important, either antenatal and postnatal. Antenatal detection screening programs are not touched in you, but preferably all pregnant women should be screened for Down syndrome, and postnatally they should be confirmed. And early intervention programs should be started at the earliest. That's why it's known as early intervention, preferably from birth onwards. Now, unless you make a diagnosis, an early intervention program is missed. Very often the diagnosis is missed, and in some cases the diagnosis is made but not conveyed to the parents. Or in other cases, it's conveyed to the parents, but the gravity of the problem has not been fully understood by the parents, and so they don't come in for a early interventional program. They realize that the child is delayed or late only by about 9 months to 1 year, and then the early intervention time is over. Counseling and support to the parents, extremely important, not only to counsel about the nature of the child, but counsel them how to handle bringing up this child. Because it's an extra pressure on the parents, especially the mother, in handling them, and rather than when compared to a normal child. And extra support and counseling should be done. And this is something very important, which is very often missed. Treat associated problems of the different systems, which I already elaborated earlier. Prevent complications, like if there's a cardiac surgery is needed, do it pretty fast rather than have a complication and then ultimately find that you cannot do anything. So also you have an otitis media with effusion, a grommet insertion if it is required. Get it done before the child lands up with a permanent ear problem. Treat complications once the complications are set in, you are not able to prevent it, and then a regular follow-up. Now, this is the most important aspect, a regular follow-up. Many parents are very much enthusiastic in the beginning, but later on they drop out for various reasons. So we have to emphasize on them the need for regular follow-up, and that regular follow-up can do wonders. Very important thing is forming a support group of parents or the caretakers. Now, this support group was of immense help to them. So how to start a support group? Get a list of children with Down syndrome in the area. Have a regular meeting once a month or once in 2 to 3 months, but regularly. A convenient place where the parents can come and go easily. Provide tea and snacks, and then a leadership by the group members. Hand it over to the group members so that they run the whole thing, and we just support them, more so in the initial stages. And that can do wonders. In Australia, what is being done is the moment a child is born in a hospital, they contact the support group members. And one of the support group members will go to the hospital, see the child, and support the parent. Tell them, oh, this is nothing. I got a child. He or she is doing wonderfully well. And then that gives more of a training and support rather than the doctor telling them, okay, this child will definitely walk or this child definitely is going to do well, because the parents may not believe. They think that the doctor is only trying to console them. But with a support group, the impetus to continue the training and a better outcome has been noted there. So forming a support group is absolutely essential, and then get the help of the support group so that they can have, the parents can have a one-to-one contact with them. So thank you very much. If you have any queries, I shall answer them during the session on queries. And thank you.